Welcome to this session of MD310 Medical Care Provider. In this session we'll be discussing medication administration. By the end of this session you'll be able to identify 3 medication references, list the 6 rights of medication administration, list at least 6 routes of medication administration, and then identify and list 3 sites for an intramuscular IM injection and the acceptable volume of medication in each site. Now suppose medical control told you needed to inject the patient with 2-diethylamino N26 dimethylphenylacetamide. You could even look at what it looked like. Do you recognize it? You need to learn medications in the names that are commonly used, and the best to learn is the generic name. That medication we just looked at, it's lidocaine hydrochloride, trade name of xylocaine, used for numbing up patients before we suture them up, and also for treating some irregular heartbeats. So where do you turn to get reliable information about the medications you need to give? How do you know when they're safe? How do you know when you shouldn't give the medication? Well, all medications, at least those sold in the U.S., come with a package insert, which gives you very good information about the medication, how it works, its names, its uses, reasons you can't give it, reasons you should give it, dosage, how it comes. It's very useful information. Your textbook also has some information about medications, at least why you would use them. The IMO's International Medical Guide for Ships is another excellent resource on the medications you can use. The physician desk reference is actually a compilation of all the package inserts of medications approved in the U.S., and so that's a handy reference. Publishing company called Tarascon produces something called the Pharmacopoeia, and it's available as an app, or you can buy the pocket version, and that tells you the drug names and the dosages and a little bit of other information. Not quite as useful as some of the other references, but very handy once you become familiar with medications. And then there's about 5 bajillion apps out there that tell you all about the medications. So your most useful app will tell you these things: the name, what class the medicine is in, how it works, 2 things called pharmacokinetics and pharmacodynamics, how the drug affects the body, how the body affects the drug, indications or why you give the drug, contraindications or reasons why you can't give the drug, side effects to look out for, things that it interacts with, that's often drugs, foods, and other chemicals, how it can be given, how much is given, how it's supplied, as a liquid, as a powder, in what concentrations, and then some special considerations. Is it safe in pregnancy? Can you give it to people with renal disease? Because if their kidneys don't work, they don't get rid of the medications, excrete them quite as well. And if they have liver disease, they might not break them down as well. So this is all important information to know. So there are considered to be 6 rights of medication administration. The right medication, given to the right patient, in the right dose, at the right time, by the right route, and you perform the right documentation to demonstrate those previous 5 rights. How are you likely in your role to give medications? Most likely you'll give them by mouth, orally. You could give them by inhalation, through the skin, under the tongue, through an IV, as an IM shot, in the ear or in the eye. Less likely, you would give a rectal medication or a vaginal medication, although those may be possibilities. It's very unlikely you would give a subcutaneous or an intradermal medication. So most of the time we give people medications orally. It's safe, it's easy, it's very effective with the medications. The dose is controlled, patients can give themselves the medications. It's slower onset, but if you don't need it to be acting immediately, this is a good way to do it. Inhalation is safe, easy, and very effective, and people inhale medications into their lungs through nebulizers or other devices. The patient needs to be cooperative with this, but it can be a very effective way of getting a medication into the lungs, particularly one like albuterol, which is really made to help the lungs directly and help people breathe. You might give it across the skin. There's only a few medications that we can do this. Transdermal are ones that absorb through the skin into the body and are circulated just as if someone had taken it by mouth or by IV. Topical are ones that are designed to act on the skin. Sublingual is given under the tongue. It's very easy. and the onset is rapid. It's as fast as giving the medication IV. There's only a few medications we do this with, and the one you're most likely to use is nitroglycerin. IV medications, you get very rapid onset, and the peak levels are reached very quickly. So you have the maximum effectiveness very quickly. But it's the most dangerous because you've got very high concentrations in the blood at a given time, and so you're at high risk, particularly if it turns out someone's allergic. They're getting a large dose all at once, and they're likely to have a severe allergic reaction. It also requires that you place an IV, which is potentially injurious to your patient, and also provides the opportunity for you to give yourself a needle stick. You'll also give medications IM or intramuscular. This is easy, it's effective, it's easier than starting an IV, but it takes longer to have onset, and you can't take the meds back once you've given them. So if they're allergic, the med is there, and there's also a risk of needle stick. For ear disease, we'll give ear drops. For eye disease, we'll give eye drops. They're good local treatments. Sometimes we give patients medications rectally, particularly if they're having seizures, and it's almost as good as giving it IV in terms of how quickly it absorbs in the peak. But people have a lot of trouble mentally with the idea of giving a rectal medication. So if you can get past that, this is actually an excellent route. Vaginal is also used for local treatment. You could give things there that would absorb just like an IV. We typically don't. Sometimes as a form of substance abuse, tampons are soaked in alcohol and then placed in the vagina, and they're absorbed there almost as fast as if the alcohol was given IV. That's not what we're doing. We're treating local infections like yeast infections with vaginal suppositories, and these are patient self-administered. So before you give any medication, you want to make sure it's the right medication and that you know what the concentration is, how much of the medication is in that form that it's being given. This is particularly important for IV or IM medications. You want to look at the expiration date, make sure that the delivery unit isn't damaged, that if it's a liquid, it's not discolored, or a solid, it's not falling apart, there's no contamination, and if it's liquid, there shouldn't be floating particles. Now, there are a few medications where you start with a powder and dissolve it into the liquid, and ultimately it should all dissolve, but while you're in that transition phase, you may have some particulates. Now, before you give any medication, you need to talk to medical control. The only exceptions are epinephrine for anaphylaxis and oxygen. Those you can give without talking to medical control. But otherwise, talk to medical control, check the patient's allergies, check the 6 rights, check the patient's allergies, do your medication check, check the patient's allergies. You need to make sure you don't give the patient something they're allergic to. And I always check right before I administer it. I ask them again, do you have any allergies, or what are your allergies? If you're going to give an oral medication, check to see if it should be given with food or away from when they eat. Find out whether it's chewable or not. Find out whether it's a liquid or a pill. Make sure you give them the right medication. If you're giving sublingual medication, it goes under the tongue. People seem to have trouble lifting their tongue, so what I usually tell them is, I want you to pretend you're licking peanut butter off the roof of your mouth. They pull the tip of their tongue right up, you drop the medicine underneath, don't let them chew it, it absorbs onto the tongue. When you give an inhalation medication, it's by a nebulizer, device that uses oxygen to make the medication bubble and vaporize, or by an inhaler, which uses a propellant to spray it, or by a crushed powder where the patient inhales and there's a wind effect that pulls the powder into their lungs. You need to coach the patient to inhale it, so typically they start to inhale, put the device on their lips, then take a deep inhalation, draw it into their lungs, and hold it in there. For ophthalmic medications in the eye, no more than 2 drops at a time, otherwise they just run out. The eye can't hold any more than that. And you put it right in the inside of the eye, where the top and the bottom part of the eyelids come together, right in that corner there. Put your drops there, they'll run out and cover the rest of the eye. When you give medications into the ear, have them lay on the unaffected side, put 3 to 5 drops directly into the canal, look at what the instructions are, and then they lay on their side for 5 to 10 minutes, and you can plug it with a cotton ball, but if they lay for 5 to 10 minutes, they should get good absorption and won't need that. Any topical medication, put the medication in the infected area, and it's treating something locally. If it's transdermal, often these come in patches, You need to know how long that patch is supposed to stay on. Some are 1 day, some are 1 week, some are 3 days. Just know how long it's effective. When you give an IV medication, you need to start the IV, and then you need to determine how quickly you can give the medication. Some of them are rapid IV push. You just squirt it right in. Some are slow IV push, usually over a minute or two. And some have to go in as a drip, and you need to figure out how long that drip needs to run. Half an hour? An hour? You need to be sure you know. To give IM shots, you're going deep into the body of the muscle. This isn't superficial. If you're doing multiple injections, you have to go to multiple different sites. I had to get the rabies immune globulin, and I had to get shots in 4 different places. You clean the site, you inject, and you put a Band-Aid on. And don't rub the site because that can actually cause the medication to leak out of the injection tract. So what sites do we use? The deltoid muscle, which is on the upper outer shoulder. You can put a total of 2 mLs into that area. The gluteus maximus, which is your buttocks area. You look at the buttocks, you draw on each side a little cross or plus that divides it into 4 quadrants, and then in the upper outer quadrant you draw another cross, and in the upper outer quadrant of the upper outer quadrant you can give up to 2 ml. In the vastus lateralis, which is the lateral anterior thigh, so the outer side, front of the thigh, you've got the lowest nerve ending density in the body, which means it's the least painful area to give a shot, and you can give up to 5 ml. So that's the deltoid up on the shoulder and the anterior lateral thigh, vastus lateralis, on the leg. So you'll have the opportunity to give controlled substances, which are medications that the government has decided have a high risk or a higher risk of abuse and dependence, and so they're put into their own special category. It takes a special type of DEA license to be able to prescribe these. Schedule 1 drugs you can't prescribe. They're drugs like heroin, which have a high risk for abuse and dependence and no medical use. Schedule 2 also have a high risk of abuse and dependence, but there's some medical indications. So hydrocodone, medication in Vicodin, Norco, Lortab, that's used for pain control fairly commonly. It's an oral medication. Schedule 3, there's a moderate abuse potential. The risk's lower for physical dependence, but there is a risk of psychological dependence, and that's buprenorphine, similar medications. So little less addiction potential than the Schedule 2, but still there. Schedule 4, there's a very low abuse risk, and some risk of dependence. There are some people who take things like dextropropoxyphene who become addicted. And then Schedule 5 is your lowest abuse potential, so Robitussin AC. There are people who abuse Robitussin AC, but the risk is fairly low. In pregnancy, there's 2 things we need to consider. First, the mother has a higher heart rate, they push more blood through their heart, and they have a much bigger blood volume. So this affects how the drug affects the body, how it's distributed throughout the body, what the concentrations are, and how effective it will be. The other problem is that some of these medications can cross the placenta and cause problems with the developing fetus, and some are even excreted in breast milk. So any reference you use will tell you what category they are for pregnancy and typically what category these medications are for breastfeeding. So the pregnancy classes include Category A, of which there are almost none because nobody does studies in pregnant women. But in a Category A, there's actually studies in pregnant women that shows the drug's safe. In B, there's animal studies that show no risk, not much human data. There's a lot of medications in that class. In Class C, there's some animal studies that show risk, but there's inadequate human data. This is a lot of the medications that we use, and use them fairly safely, but there's risk there. D, there's some benefit, but there's human data to show that there's also risk, so these you have to be more cautious with. And finally, Category X, the risk always outweighs the benefit, and we never use these in pregnant patients. Please complete the knowledge review for this session, and if you have any questions, please contact your instructor or professor. Thank you very much.